I will finish up and talk about other potential targets, specifically PARP, MEK, and BRAF, but not in that order. My disclosures over the past 10 years, I've been accused of pharmaceutical promiscuity, and this is proof. So are these really actionable targets? And we'll go through some of the data. Again, the RAS cascade is well known to most of you, the kinase pathway, with downstream effects on MEK and ERK1, ultimately leading to tumor proliferation, growth, and survival. We've known about KRAS for probably a quarter of a century now as one of the first mutations identified. The original lung cancer mutation consortium data was about 22%. It's probably closer to 25 or 27%, but at least as yet we have not identified a specific agent that will consistently target this mutation. These are examples of some of the MEK inhibitors that are being looked at in both KRAS mutant and wild type. I'm going to concentrate on selumetinib, on Pasiani's data from ASCO 2013, as well as some of the trametinib data that exists. And again, all of this is reproduced in your book. This is a randomized placebo-controlled phase 2 double-blind trial in the second-line setting in KRAS mutant patients looking at docetaxel alone or in combination with selumetinib. For those not familiar with this agent, it's a potent selective allosteric inhibitor of both MEK1 and MEK2 downstream from KRAS. If you look at these plots here, in red and blue are the cell lines that are both BRAF or KRAS mutations, and you can see a marked reduction in cell viability with the addition of selumetinib. Clinical activity has been seen in non-small cell, not superior to pemetrexed, but it seems to be on par. It's safe, at least, with a manageable toxicity profile in combination with docetaxel. And in this preclinical KRAS mutant model, you see a additive, if not synergistic, effect for the combination compared to either single agent or the vehicle. And that really gave rise to the phase 2 double-blind trial presented by Pasiani, looking at standard dose docetaxel, either alone or combined with selumetinib. The main entry criteria, besides being second line, was the presence of KRAS mutant. The primary endpoint in this rather small study was overall survival. Here's PFS. You see more than a doubling from 2.1 to 5.3 months with a hazard ratio of 0.58. Again, this was actually statistically significant using a one-sided p-value, and a trend at least for improved survival from 5.2 to 9.4 months at the median. Hazard ratio here is 0.80, and this trial is really woefully underpowered to identify a survival benefit. Response rate was 37%, one of the best that we've seen. Again, very small numbers, unbelievably low response rate for single-agent docetaxel, but if you look at the live and free from progression at 6 months, clearly a putative advantage for the combination of selumetinib with docetaxel. No reason you can't do waterfall plots with chemo alone, and here it is, docetaxel versus docetaxel and selumetinib, again looking better for the MEK inhibitor combination. This is now being looked at prospectively in phase 3 in the second-line setting. So one of the first KRAS-specific KRAS mutant-specific trials. We see data for selumetinib and for trametinib in combination with second-line treatments. Fairly consistent response rate, 17 to 37%, manageable toxicity. Also single-agent data. These are waterfall plots for a randomized trial looking at docetaxel versus trametinib, another MEK inhibitor. And you're seeing credible activity, at least for the single agent in patients with KRAS mutant. But you also see activity in the absence of KRAS mutant. So KRAS wild type in combination with chemo, 16 to 30% or so. So is this really a KRAS mutant specific approach, or is this just a combo chemo approach with MEK inhibitors? Go to BRAF. This is relatively rare. It's only 1 to 2% of all adenocarcinoma. Phenotypically, these patients are very similar to those with KRAS, usually smokers. This was a phase 2 trial presented a year and a half ago by Dave Blanchard from France. And it's really the model of what we're starting to do here in the US, but France is way ahead of us. This is an industry, academic, federal consortium. Think about that. where all patients diagnosed with cancer have their tissue sent into central labs for assays, and then clinical trials are available someplace in France, no more than an hour or two away, by either car or train based on those molecular abnormalities. Would that we could do something like that here in the US? In any event, a straight phase 2 trial looking at dabrafenib and BRAF V600E mutation positive constitutes about 50% of all BRAF activating mutations in lung cancer. It's relatively more common in melanoma, 80%, associated with decreased progression-free and overall survival. And you see very consistent response rates for vemurafenib and dabrafenib in this setting. So at the initial design, it was 20 patients, one or more prior lines of treatment, BRAF mutant positive, no restriction on the number of systemic agents, up to PS2. The only exclusions were prior exposure to a BRAF inhibitor, a MEK inhibitor, or progressive brain metastasis. So here are the baseline demographics. Again, this is a French-based trial, so the majority were male. They did allow PS2, 16%. Surprising number, 30% or so, were never smokers, which I would not have predicted. And you can see 32% had 2 or more lines of prior treatment. Overall response rate 40%. We do not yet have PFS or overall survival data. Toxicity pretty much consistent with what we've seen in melanoma, including grade 3 and 4 rash, fatigue, anorexia, asthenia, nausea, and vomiting, fever. It's not the easiest drug. 2 out of 25 patients actually developed cutaneous squamous cell malignancies, and there was 1 grade 5 event. Here's the initial waterfall plot for the first 20 patients, majority exhibiting at least some response, and the actual response rate was 40%. And these are swimmer plots, so you're actually charting response and duration of therapy, and you can see about a quarter of patients went 6 months or more. And just examples of CAT scans showing major improvement. You sort of see this foamy infiltrative mass in the right lung almost completely disappearing after 6 weeks of dabrafenib, and again, nodular mass with an effusion, at least 3/4 resolved on subsequent follow-up at 5 to 6 months. So a lot of outstanding questions. How do we find enough patients to study this abnormality? No single institution can do this. We need a major blanket consortium effort that looks at multiple different agents in the context of tissue screening and molecular mutation or translocation identification. How on earth can you get regulatory approval? We've actually gotten some approvals based on just these data alone to use the drug. Why do some of these folks not respond, and what do we do with the non-V600 mutations? So this is their study going forward. They plan a total of 60 patients with dabrafenib alone, and they're going to actually do combination MEK and BRAF inhibition with dabrafenib and trametinib. So France is leading the way in defining how to treat BRAF mutant. Finish up with PARP inhibitors. At least 17 members of the PARP family have been identified. PARP 1 and 2 are the only members known to be activated by DNA damage and may compensate for each other. And PARP 1 pretty much localizes to the site of DNA damage and recruits proteins that can mediate repair after DNA damage. And a double knockout will result in embryonal lethality in mice. PARP inhibitors clearly have a broad potential application in sensitizing hypoxic tumor cells in combination with either radiation or chemotherapy, and obviously this can extend not just to non-small cell but to small cell, and in combination with targeted agents. Platinum compounds exert cellular cytotoxicity. Enhanced DNA repair capacity is a known mechanism for resistance to platinum, and combination PARP inhibitors with platinum have demonstrated preclinical synergy. So cancer cells, usually though not always, can acquire platinum resistance by hyperactivating PARP, hence becoming sensitive, at least in theory, to the effects of PARP inhibitors. There's a huge number of drugs that have been investigated. Some of these, in fact, may not really be PARP inhibitors, although they were labeled as such. I'm going to really concentrate on some of the early data with aniparib and then veliparib, and I apologize to those of you who omit your favorite PARP inhibitor. This was work by Novello, a randomized phase 2, GemCis plus or minus aniparib, which many now think is not necessarily a PARP inhibitor. Multinational effort, nearly 120 patients. The aniprib was given on this very inconvenient day 1, day 4, twice weekly for 2 weeks out of 3 schedule with standard gem-cis. They always use bigger doses of gem in Europe. Up front, treatment naive, good performance status. Here are the demographics, fairly typical European trial with a huge predominance of men, 3/4, almost all with stage 4 disease, and the vast majority having adenocarcinoma. Response rate was actually better for the control arm, 26% versus 20%. You can see primary disease progression was a little bit lower in the aniprib arm, a little bit more anemia and nausea, though no real major differences when it comes to toxicity. And this is extraordinarily hard to see, but there's about a 1.5-month improvement in PFS for the aniprib arm with a hazard ratio that I'm having trouble reading. I think it's just 0.9, obviously not significant. And again, hard to see. Survival was slightly better, about 2.5, 2.8 months. Hazard ratio looks a little bit more impressive at 0.75. This trial was really underpowered to identify a significant difference. But with all of those caveats, caution interpreting this 1.4-month improvement in PFS and 2.7-month improvement in median survival, reasonable toxicity, they did go ahead with a phase 3 trial in squamous specifically, based on PFS data that looked a bit better there, comparing gem-carbo with or without aniprib. 825 patients were planned. I believe the trial was concluded in 2013 with this press release. There's nothing like science by press release. It's cut off on the, oh, it's not cut off there, but basically the randomized phase 3 ECLIPSE trial failed to reach its primary endpoint. And I think when you see phase 2 data of that sort, it's really no major surprise that it did not pan out. Veliparib is another, is almost definitely a PARP inhibitor, desirable pharmacokinetic and pharmaceutical properties with linear PK dosing, and in vivo preclinical activity with a whole host of agents, including topo-1 inhibitors, platinum, alkylators, temozolomide, and radiation. So pick your poison, you can combine it. This was presented just a month and a half ago at ESMO, looking at carbopac with or without veliparib, 2-to-1 randomization in our usual population of treatment-naive advanced non-small cell. 158 subjects enrolled. You can see almost even split between squamous and non-squamous. Majority, huge majority, were current smokers, which is intriguing. PFS was the primary endpoint with OS secondary endpoint. A majority of patients on this trial came from Russia and the US, and certainly the plurality from Russia, which may explain the current smoker status. Both arms were well balanced. Again, huge male predominance at 3/4. You see about an even split, as I said, between histologies. And when it comes to toxicity, slightly higher grade 3 and 4 events in the veliparib arm, although when you look at individual toxicities, very little difference. This agent at this schedule does not seem to exacerbate typical chemotoxicity. Look at response rate, no major difference, 31% versus 28%, but you do see a trend toward improved PFS with a hazard ratio of 0.74. And overall survival, 9.1 to 11.1 months with a hazard ratio of 0.77. This seems to be more pronounced in the squamous population. Again, this is a bit light, but the waterfall plots suggesting maybe not a higher response rate, but more profound responses. And many of these responses are much more durable. And if you look specifically at the squamous cohort, you see a 2-month improvement in PFS and at least a 2-month improvement in overall survival with nice separation of the curves. So this has actually laid the groundwork for a phase 3 in squamous cell, carbopac with or without veliparib, looking for 900 subjects. The primary endpoint, as it should be, is overall survival. There will be biocorrelative along with this study, and again, essentially metastatic disease. Is there a role elsewhere? Well, ECOG is actually looking at this agent in small cell. It can potentiate platinating agents, etoposide, and radiation in cell line specific manner. This is an H128 xenograft. You see the individual agents and the combination showing sustained reduction in growth that actually can last beyond the cessation of treatment. So ECOG 2511 is open, probably at an institution near you, taking standard cis etoposide, adding veliparib. Started out with the phase 1 demonstrated safety, no DLTs in the first 3 patients. At the top dose, 1 DLT, so the cohort was expanded and proved safe. And this is the current dose that's being tested, 100 BID for 7 days with a fairly fixed dose. It's 100 per meter squared, not 1,000, I apologize. That would be a major overdose. We have to amend that. And here's the randomized phase 2 schema of cisotopicide, placebo-controlled versus veliparib, with the usual caveats. Of course, getting small cell patients onto clinical trials is tough. PFS is the primary endpoint, looking for a 38% reduction in the HR to about with a p-value of 0.10, response and overall survival of the secondary endpoints. So my conclusions are shown here. The MEK inhibitors have a potential role in KRAS and BRAF mutant non-small cell. Phase 3 trials are ongoing. Whether or not they pan out remains to be seen, and whether they are really specific for KRAS is unclear. Phase 2 activity has been established by BRAF inhibitors, likely insufficient numbers to actually pursue phase 3 trials. And finally, the role of PARP inhibition is still undetermined. Potential promise for I can't pronounce it, veliparib, and other PARP inhibitors in both non-small cell and small cell, but it'll be quite a while till we see the final result. So thank you for your attention. You've just got a whirlwind tour through receptor tyrosine kinase inhibitors and PARP, BRAF, and MEK inhibitors, actually.